Angina. Angina pectoris. Angina pectoris is a clinical syndrome characterized by episodes of chest pain. It occurs when there is a deficit in myocardial oxygen supply, myocardial ischemia, in relation to myocardial oxygen demand. It is most often caused by atherosclerotic plaque in the coronary arteries. It may also be caused by coronary vasospasm. Development and progression of atherosclerotic plaque is called coronary artery disease, CAD. Atherosclerotic plaque narrows the lumen, decreases elasticity, and impairs dilation of coronary arteries. The result is impaired blood flow to the myocardium, especially with exercise or other factors that increase the cardiac workload and need for oxygen. Other causes of myocardial ischemia: decrease in amount of oxygenated blood reaching the heart, anemia, carboxyhemoglobinemia, cigarette smoke, increase in myocardial O2 demands, thyrotoxicosis, hypertension. Myocardial ischemia occurs when myocardial oxygen demand exceeds myocardial oxygen supply. Myocardial oxygen demand increases with increased contractility. Myocardial ischemia occurs when myocardial oxygen demand exceeds myocardial oxygen supply. Myocardial oxygen demand increases directly in proportion to heart rate. Increases with increased contractility. Increases with increased wall tension, i.e. increases with increasing preload or afterload. Myocardial oxygen supply. 1 coronary blood flow equals pressure, resistance. A coronary perfusion pressure. B coronary vascular resistance. 2 O2 carrying capacity. A oxygen saturation of the blood. B hemoglobin content of the blood. Risk factors of IHD: sex, age, weight and family history. Diets, with high content of unsaturated fats and low content of natural antioxidants. Smoking. Lack of regular exercise. Alcohol abuse. Diseases as hypertension, hypotension, thyrotoxicosis, D.M. Hyperlipidemia. Types of angina pectoris. 1. Classic angina. Classic angina, also called stable, typical, or exertional angina, occurs when atherosclerotic plaque obstructs coronary arteries. Chest pain is usually precipitated by situations that increase the workload of the heart, such as physical exertion, exposure to cold, and emotional upset. Recurrent episodes of classic angina usually have the same pattern of onset, duration, and intensity of symptoms. 2. Variant angina. Variant angina, also called atypical, Prinzmetal's, or vasospastic angina, is caused by spasms of the coronary artery that decrease blood flow to the myocardium. The spasms occur most often in coronary arteries that are already partly blocked by atherosclerotic plaque. Variant angina usually occurs during rest or with minimal exercise and often occurs at night. It often occurs at the same time each day. Pain is usually relieved by nitroglycerin. Unstable angina, UA. Unstable angina, also called rest, pre-infarction, and crescendo angina, is a type of myocardial ischemia that falls between classic angina and myocardial infarction. It usually occurs in clients with advanced coronary atherosclerosis and produces increased frequency, intensity, and duration of symptoms. It often leads to myocardial infarction. It usually develops when a minor injury ruptures atherosclerotic plaque. The resulting injury to the endothelium causes platelets to aggregate at the site of injury, form a thrombus, and release chemical mediators that cause vasoconstriction, e.g. thromboxane, serotonin, platelet-derived growth factor. The disrupted plaque, thrombus, and vasoconstriction combine to obstruct blood flow further in the affected coronary artery. When the plaque injury is mild, blockage of the coronary artery may be intermittent and cause silent myocardial ischemia or episodes of anginal pain at rest. Thrombus formation and vasoconstriction may progress until the coronary artery is completely occluded, producing myocardial infarction. Endothelial injury, with subsequent thrombus formation and vasoconstriction, may also result from therapeutic procedures, e.g., angioplasty. Because unstable angina often occurs hours or days before acute myocardial infarction, early recognition and effective management are extremely important in preventing progression to infarction, heart failure, or sudden cardiac death. Pathophysiology of UA and ME. 1. Plaque vulnerability and extrinsic triggers result in plaque rupture. 2. Platelet adherence, aggregation and activation of the coagulation cascade with polymerization of fibrin. 3. Thrombosis with subtotal, UA, or total coronary artery occlusion, ME. Stable angina, symptoms. Mid-substernal chest pain. Squeezing, pressure-like inequality, closed fist equals Levine sign. Builds to a peak and lasts 2 to 5 minutes. Radiation to left arm, neck, jaw or back, mistaken for arthritis. Associated with shortness of breath, sweating, nausea and vomiting, mistaken for indigestion. Exacerbated by exertion, cold, meals or stress. Relieved by rest, NTG. Increase in frequency, duration and severity. Unstable angina, symptoms. New onset angina. Increase in frequency, duration and severity. Decrease in exertion required to provoke. Prolonged episode, greater than 10 to 15 minutes. Failure to abate with SLNTG. Onset at rest or awakening from sleep. Summary, symptoms of angina. 1. Sudden pain in the chest which may radiate to left arm and neck, rang from mild ache to severe pain. This pain fades quickly equals stable angina. 2. If pain is experienced at rest equals variant angina. 3. If frequent pain is experienced at rest, comes and goes, and with little effort equals unstable angina. Non-pharmacological management. Optimal management involves lifestyle changes and medications, if necessary, to control or reverse risk factors for disease progression. Non-modifiable risk factors include age, race, gender, and family history. However, other factors can be managed as follow. 1. Treatment of predisposing factors, hypertension, anemia, thyrotoxicosis, hyperlipidemia. 2. Stop the use of drugs that increase cardiac workload, e.g., adrenogenics, corticosteroids. 3. Rest exercise program. 4. Avoid heavy work and stress. 5. Reduce weight and diet regulation, small frequent meals with high content of natural antioxidants and low content of unsaturated fats. 6. Stop smoking and avoid alcoholic beverages as well as stress. Additional non-pharmacologic management strategies include surgical revascularization, e.g., coronary artery bypass graft, and interventional procedures that reduce blockages, e.g., percutaneous transluminal coronary angioplasty, PTCA, intracoronary stents and laser therapy. Angiogram in unstable angina, after stent deployment. Pharmacological treatment of angina. Goals: increase CA blood flow. Vasodilators, no donors, CAR2 plus channel antagonists. Decrease demand on heart. Beta-adrenergic receptor antagonists. ACE inhibitors. CAR2 plus channel antagonists. Treat CAD. Decrease cholesterol. HMG company A reductase inhibitors equals statins, lower blood cholesterol, prevent plaque formation. Aspirin, prevent thrombi. Antioxidants, con. Pharmacological treatment. Variant angina. It is necessary to relieve the coronary vasospasm by vasodilators, nitrovasodilators, Ca2 plus channel blockers and AK. Never give beta blockers. They can actually cause coronary vasospasm. This is because if all the beta receptors are blocked, the excess noradrenaline stimulates alpha receptors which cause vessel constriction, worsening the case. Stable and unstable angina. The aim of therapy is to reduce the myocardial O2 demand. This is because we already have maximal blood flow, it is not possible to increase the flow anymore. 1. Decrease preload. Nitrovasodilators. 2. Reduce myocardial contractility. Beta blockers. 3. Decrease afterload. Ca2 plus channel antagonists. Nitrovasodilator. AK. 4. Consider platelet glycoprotein inhibitor and, or low molecular weight heparin, for UA. Organic nitrates. High lipid solubility, absorbed sublingually, absorbed across skin, rapidly absorbed with quick onset, 1 to 2 minutes. Nitrates form no, causing marked dilation of large veins, thus decreasing preload, cardiac work, cardiac oxygen requirement. Nitrates also improve collateral blood flow, decrease coronary vasospasm, and inhibit platelet aggregation. At high doses, nitrates cause arteriolar dilation, decreasing afterload cardiac and oxygen requirement. Nitrates decrease infarct size and post-ME mortality. 1. Nitroglycerin, NTG. Nitroglycerin is available in oral, sublingual, transdermal, and 4 forms. Cheap, prophylactic. 2. Isosorbide dinitrate. Mono or dinitrate, oral, some extended release. Longer duration of action. Side effects: headache and flushing, orthostatic hypotension, reflex tachycardia. Conversion to nitrites at high concentrations oxidizes ferrous iron, converts hemoglobin to methemoglobin and thus reduces O2 supply. Tachyphylaxis require rest periods of greater than 12 hours. Nitrates and the nitric oxide pathway. Beta blockers, used prophylactically, not used to treat acute angina. Atenolol, acebutolol, metoprolol, propranolol. Used prophylactically, not used to treat acute angina. Increases exercise tolerance of patient, reduces frequency of attacks. Antagonize beta-1 adrenergic receptors expressed on cardiac myocytes. Decrease heart rate, decrease CO. Decrease preload/afterload. Net effect: decrease myocardial O2 demand. Side effects: few in healthy individuals. Many potential side effects secondary to underlying diseases include cardiac failure, fatigue, hypoglycemia, impotence. Contraindicated in asthma, diabetic and variant angina. Ca2 plus channel antagonists. Given prophylactically, do not reverse acute angina. Inhibits Ca2 plus influx through voltage-gated L-type Ca2 plus channels in blood vessels as with amlodipine, nicardipine. Relax arterial smooth muscle not venous. Increase blood flow to the heart. Reduce peripheral resistance, cardiac afterload. No effect on avenue nodal rate and conduction. Net effect: increase O2 supply. In heart muscle as with verapamil and diltiazem. Inhibit myocyte contractility and potent negative inotropic actions equals decrease CO. Depresses avenue nodal rate and conduction. Contraindicated with beta blocker. Net effect: decrease myocardial O2 demand. Side effects: dizziness, headache, constipation, flushing, fatigue, bradycardia, reflex tachycardia, with arterioselective CGMP phosphodiesterase inhibitors. cGMP phosphodiesterases convert cGMP to GMP. There were numerous subtypes of cGMP PDEs. PD5 prevalent in vascular smooth muscle. PD5 inhibitors inhibit breakdown of cGMP. Increase in cGMP leads to vasodilatation. Sildenafil, Viagra. Vardenafil, Levitra. These drugs cause vision problems, hypotension, GERD, SNES effects. Optimal for treatment of angina in combination with erectile dysfunction. Okay. Acute myocardial infarction. Total thrombosis, occlusion of coronary artery, onset of ischemic cascade. Prolonged ischemia, altered myocardial cell structure and eventual cell death, release of enzymes, CPK, LDH, troponin. Altered structure, altered function, relaxation and contraction. Consequences of altered function often include exacerbation of ischemia. Ischemia begets ischemia. Consequences of ischemia, ischemia begets ischemia. Systolic dysfunction, loss of contraction. Decrease cardiac output. Decrease coronary perfusion pressure. Diastolic dysfunction, loss of relaxation. Dyspnea, decrease O2 delivery. Increased wall tension, increased MO2. All three give rise to stimulation of sympathetic nervous system with subsequent catecholamine release, increased heart rate and blood pressure, increased MO2, ischemic cycle, ischemia, infarction, diastolic dysfunction. Systolic dysfunction. Chest pain. LV diastolic pressure. Cardiac output. Pulmonary congestion. PO2. Wall tension. Catecholamines. Heart rate, BP. MVO2. Symptoms of ME, severe chest pain suddenly occur and last for long period. Sweating, pale due to hypoxia. Breathlessness. Nausea and vomiting. Moderate fever, due to cell necrosis. Tachycardia,